Welcome back to the Performance Prescription Podcast. As part of our top 10 RHTP traps series, we've been discussing some of the most common mistakes that health centers are making when implementing transformation programs. Today, we're going to take a step back from that because while a lot of organizations have been focused on implementation, there's still a tremendous opportunity for funding nationally that remains in that planning and application stage. So it's even before projects even funded, there are a few critical mistakes that can weaken an application and reduce the impact of the funding opportunity. So, to help us unpack a couple of those biggest application traps, we're joined by Rebecca Mankin of Mankin Consulting. Rebecca's personally led FQHCs in the past, and she's helped a lot of organizations navigate grant funding, proposal development, strategic planning, and program implementation for years. So, Rebecca, thanks for joining us.
Thank you, Jared. Glad to be with you.
And I've also got Jerry Hofer here. Jerry's our VP of Development at Target Continuum. Thanks for joining us and being back.
You bet, Jared. Happy to be on here. I'm really looking forward to today's conversation. Seems like RxTP and it's really moving fast today. I really kind of liken it to herding cats nowadays. It can be kind of challenging to follow it sometimes. But we found that there are dozens of strategy and execution related RHTP traps. But today we're really kind of honing in on two of the bigger HTTP traps that really can derail an application before implementation even begins. Firstly, it's allowable use of funds, and the other trap that we'll talk about is alignment. So, Rebecca, one of the biggest misconceptions that we hear all the time is that patient outreach and education or awareness engagement activities are not allowable under the transformation funding programs. So where do you think that FQHCs and RHCs are getting that misconception from?
Well, Jerry, I think there's been some shifting in different grants and notice of awards that have come out in the last year or two. And so with that, I think that has caused community health centers particularly and some states to be very, very cautious in how they put their grants together. And I think that while I understand that vantage point, that there is an allowance for the use of the funds for outreach and marketing. And that in rural communities, it's paramount that you reach your audience, a targeted audience. And to use those funds effectively, you have to come up with a plan on how to do that, right? And part of that is, looking at how you can incorporate what you need to make that program successful into the grant application. And so part of that is obviously targeted marketing and outreach efforts and tying that, weaving it into a well-written grant application as to how, by doing that, those individuals are going to see improved health outcomes or a betterment of their situation. And so an access that maybe they didn't have before. They didn't know that the services existed, or they maybe had some barriers preventing them from getting those services before, but now they're able to use telehealth and do that so that they aren't missing work, etc. And so things like that are really pretty easy to overcome as long as you kind of partner with someone that helps you weave that blanket into the grant application.
Excellent. Very good, Rebecca. So understand that one of the things that we're seeing more from CMS nowadays is that there seems to be a little bit more scrutiny on funding and not just allowable use of funds, but overall. Can you speak to that at all? What you might be hearing?
Yeah, I do think that there was a time period that we saw some changes in how grant funding was, and the policy around grant funding is to be handled. And so there's been some changes in the OMB guidance that's recently come out. It's got a lot of the organizations looking at that, trying to comment on those rules and regulations. So that takes a lot of time. And as you can imagine, with safety net providers, there's a limited amount of time that you have, and they are stretched really beyond capacity at this time. And so the more and more regulations and rules that continue to come out that are changing the environment, it takes people away from being able to do, for instance, writing grant applications for a rural health transformation grant because they're so interwoven and having to work on compliance issues and making sure that they understand the regulations and things like that. So there's a lot going on right now. And the one beautiful thing about community health centers and those in the rural communities is they're resilient. And that is so important because they really do stay focused on the mission and why they're there and what they want to be doing and who they're serving. And so I applaud them for that. It's definitely drawn me into this arena, and I love that they have that passion to keep people getting the care that they need and providing care to their communities. So, and best serving them. So, they'll get through this. And, there's about 1,400 of them, and they are very resilient and they will fight for their mission. And in doing so, they'll come out stronger on the other end.
Yeah, so overall funding's a little bit different than it might have been back in the COVID or ECV or ARPA days, would you say?
Definitely. Yeah,
Yeah.
back in the COVID days, it was something that we hadn't seen before in community health centers. Obviously, it changed the whole environment of how you were providing healthcare services. And so it changed the whole paradigm of your healthcare modeling and how you're going to best be able to meet the needs of the community while having those restrictions in place and things like that. So again, it was a great example of, having to be flexible and being willing to make changes and pivot. And so community health centers are amazingly equipped to do that and adept at it. And so I think that with the changing times that we're seeing today, yes, it is taking those individuals away from being able to maybe write the grants or do the program development or do the outreach activities, the marketing activities. If they can look to others that can maybe come in and partner, at least on a short-term basis, to help them with those activities that maybe they can't perform, that'll help them through these times as well as an option.
The other thing that we commonly see is organizations investing in technology, workforce initiatives, or new services, but never really building any awareness around them. So if patients don't know the services exist, adoption never happens. But what are your thoughts on that?
Yeah, I do think again, that goes back to sometimes the best made plans that you put together, they can fail in execution. And I don't say that flippantly, but they really can. And I see a lot of organizations, they have well intended plans and strategy and things like that. But when it comes to the execution and the rollout, sometimes that's the area where they could use some help.
Well, Rebecca, thinking back the couple of years that you've been in FQHC leadership, can you think about any specific examples where maybe a FQHC or an RHC really kind of misunderstood what was actually allowable?
Yeah, I've seen some organizations try to, for instance, let's say that they've had a program that's been going on for a long time and they've been paying for those services on a routine basis. And then some grant money comes along and they think, well, maybe I could use that grant money to pay for that existing service, that existing funding stream that's already taking care of things. We can pay for that. And that unfortunately is viewed as a no-no. And we don't do that because they call that supplanting. And so you actually are taking funds that you normally use to pay for your routine services and supplanting using the grant funds in lieu of those. And so those kind of things can happen. The key is really understanding and having someone in the finance area or accounting area that understands grants, that helps on an interdisciplinary team to know the things that you can do with grant funds and the things that you can't do with grant funds, and making sure that you're coding things appropriately so that you can go back and have the documentation to have it as support for demonstration that you're not supplanting the funds. You're actually using them in accordance with the grant, and you're tracking them in your general ledger and keeping all the I's dotted.
Excellent. Well, thank you for that. So really, as far as the allowable use of funds is concerned, the takeaway here is really pretty simple. Don't assume that an activity, outreach, marketing, advertising is prohibited just because it involves communication or outreach. Make sure it supports your program objectives, aligns with guidance, and connects directly to measurable outcomes.
I agree. There's some pretty cool things that I've seen these funds be used for, and they've addressed some of the critical needs in the community health centers. There's a lot of health centers, hospitals, banks, lots of different entities that are being impacted across the economy by cybersecurity, ransomware attacks, things like that. So these funds can help with that. And so I can tell you that there's many, many centers that need them. Many centers, until more recently when these things were coming down, many of them didn't have cybersecurity insurance. They didn't have the necessary firewalls in place, encryption in place, compliance software monitoring. And so that's something that I've seen community health centers use the funds for. Also, hospitals in the areas use those funds. So that's something that's very good. Behavioral health spaces and telepsychiatry in rural areas. Psychiatry is a specialty. That's a novel concept in many rural communities. You have to travel hours. I'm right here in Sedalia, Missouri, rural Missouri. And I can tell you, you're going to travel an hour, 2 hours in order to get, if you needed psychiatry services, many specialty services. But with these funds, it can open up avenues of having the opportunity to do telehealth. One of the benefits of COVID was I try to look back and reflect retrospectively. We learned that telehealth can be done. And telehealth in the specialty arena is critical for the community members. And so there's psychiatry, dermatology, cardiology, neurology, all those different specialty services that now we can connect our patients to those groups and do that through telehealth and have consults, have services being provided to them so that they can be in the best health possible. And so those are some of the neat things that I'm seeing folks use it for. Remote patient monitoring. That is another outside the box idea. It's been around for the last couple years. More and more community health centers are using it. It's remote patient monitoring devices. So let's say that you have a patient that continues to go to the hospital because they're having high blood pressure. You can have that remote monitoring device on that person and have them in their home be able to take their own blood pressure. It reads the information, sends the information to the provider. We can be monitoring that from afar, and we
Yeah,
can help see that there's a trend coming. The blood pressure is going up. We need to have a nurse give that patient a call, find out what's going on, what might be causing that, see if we can try to intervene. And so that's the beauty of
yeah,
the things that are available at your fingertips now, which
yeah,
we didn't have that before. And especially for the underserved and uninsured, that was you just wouldn't even think of it.
yeah,
That's usually for insured patients only.
no doubt.
So having the funding that's available to try to help those individuals and help improve their health care is pretty exciting.
Yeah, no doubt, Rebecca. So anyway, the second thing that we wanted to touch on very briefly had to do with alignment. And really, it's probably one of the biggest application traps that we've seen. And from your experience, Rebecca, have you, as you looked at applications and so forth, what does alignment mean from a grant writer's perspective?
Yeah, I think that what I've oftentimes seen is that there sometimes is a disconnect between strategy and execution. And I talked about that a little bit at the top, that, there could be really good intentions and the strategy is clear. It's clear what the guidance is, what we want to do with these programs. We can put it together, but we can miss some key things for executing the plan. And so if we miss that, then we may not have the outcomes that we need to have in order to demonstrate that the funds were used successfully, right? So we need to make sure that when we get these funds that we are thinking through and on the front end of the project, be thinking about how am I going to make sure that we have success outreach activities, that we market to the targeted population that we need to in order to get them to understand that we at this health center can help them. And so there's ways that we can do that, and making sure that we weave that into the grant application, that we weave it into the budget, that we make sure that folks do know about the great programs that we have available and that we pull it off. We're able to demonstrate through the data that comes into our health center that we are seeing improved patient health outcomes as a result of this. And without those types of things being executed well, unfortunately, that's where you'll have disconnects happen.
Got it. So without naming names, Rebecca, could you think of any examples of any projects that were technically pretty strong, but really didn't align with the state's priorities?
Well, it really depends on, in my opinion, if the people did the homework on the front end. My pop would say poor planning leads to poor performance. And I believe that sincerely. If you do the planning on the front end, you involve the community on the front end, you involve stakeholders on the front end of the process, you get that plan together, it's a collaborative effort, then you can take that to the state and the state will be understanding that you really know what you're doing, right? I've seen that miss happen. And it's because folks throw the applications together. They don't do enough planning on the front end. They don't do enough involvement, stakeholder involvement, to really spell it out in their applications as to what they're doing and what are these funds going to show us. When these funds dry up, what do we have for outcomes? Because that's what the states want to see. They want to see that this seed money is going to develop into something that is showing results in a positive direction for healthcare and changing the trajectory of healthcare costs, right? So hopefully in a downward direction, because we're doing more on the front end to prevent folks going to the hospital. We're keeping them in their homes, not in nursing homes or, things like that. That's less costly care. It's where the people may want to be, is at home rather than in a nursing home. Or by all means, they don't want to be in a hospital, right? They want to be home as long as they can. And so I think that's the thing that I would give as guidance, is just making sure that you're doing the pre-planning in advance when you're putting those applications together to demonstrate the outcome's going to be positive once the seed money goes away.
So in short, if I'm an organization and I'm applying for RHTP funding, I need to start with, hey, how can my plan support the state's plan rather than how can my plan support my plan?
You bet. You bet. So, the states are definitely equipped and they understand the importance of prevention and chronic disease management. Public health entities are all over that. They understand that very well. So, working with the state health department, looking at the hospital, every 3 years, I think, there has to be a needs assessment that's done in communities, right? By hospitals. Those community health centers should be rightfully engaged in those at the table discussions about how to put those needs assessments for the communities together. So there's resources right at your fingertips that you can go and pull from. You can pull from your state data, your chronic disease management activities, what is being shown in your state as to be a big issue, comorbidity data. The data is out there. We've got it. The states have it. So if you grab that information, you utilize that in your plan, you also look at your hospital data about the needs assessment in your communities. What are the top issues that we want to do in our community? Have it blend in that information. And that's how you put together a really helpful plan and application as to how you're going to demonstrate those outcomes on a go forward basis. And so then you're really working with your stakeholders, your partners in the community, but don't just pull from the remote resources that are out there on the internet. You got to sit down and have those discussions. There's got to be face to face communications as well, and activities, committee meetings, things like that, forums for stakeholders to give feedback on your idea before you submit it as a grant application. And you get that buy in from the local community and your partners in the community. So, including that information is definitely best practice.
100% makes total sense to me. So in the end, when alignment and your allowable use of funds come together and you have that all figured out, organizations really put themselves in a much stronger position for funding success and also future funding success for RHTP. Rebecca, we really appreciate you joining us today. It's been very insightful,
Well,
and
I appreciate being here.
yeah, you bet.
Appreciate it, Rebecca, and yeah, thanks for helping us illuminate those traps and just all the other insights you have coming here. Best of luck with everything you have going on.
Okay. Well, thank you guys.